Welcome to this Monday morning's education session. So just for those who don't know, my name is Chris Carrigan. I'm the data advisor for Use My Data. I'm part of a really small Use My Data secretariat, which is Alison Elizabeth, who's also here, and myself. And today's session has been requested by several people, actually, over a good few months. It's on the subject of population health management, which we're hearing more and more about. So it's really good this morning. We've got two researchers, Julian and Felix from Plymouth and Exeter, here to talk about with us about this morning. They'll give you an outline of what population health management is, and then we're also going to ask what you think about some ideas that they've got that they're thinking of doing in this area to get your views about it. So you'll get a chance not just to hear the principles, but also to think about some real practical examples and bring your voices to that. So that's really all I wanted to say, and I'm going to hand the floor to Julian and Felix to introduce themselves and start us off, if that's all right.
Thank you, Chris. Hopefully you can all see me. My name's Julian Elston, and I'm a researcher at Plymouth / Exeter Uni. So today we're going to talk about population health management, but I think the first thing to do is say, well, what is population health? What do we mean by population health before we stick the management on the end? And I don't know if I could just show the next slide, but essentially what we're talking about is the framing of population health management as in population health. So we're talking about thinking about health, what contributes to our health, what makes us healthy, and recognizing that's not just how we behave and our lifestyles, how much we might be active or how much we drink and all that kind of thing. It's also related to how much we earn, whether we're employed, where we live, our housing conditions, things like debt. And also our health depends on where we live, our communities we live in, who we live in, how supportive they are, as well as our kind of wider health system. So population health recognizes all those are really key ingredients to our health and aims to, so in that sense, it's aimed at improving our health of the entire population. So it's not just about health services, it's about thinking about populations themselves, groups, communities, neighborhoods, those kind of populations we're thinking about. And it's about improving our physical and mental health outcomes, thinking about more broadly, not just health, but health in the sense of well-being. And one of the strong emphasis is around reducing health inequalities. So that's looking at the differences that we know exist between different populations and different groups in our communities. And some of them are quite stark. We know that there are, for example, even within cities, quite often you can see a sort of 10 to 15 year difference in life expectancy between different wards of those cities. And they're cross-defined populations. As I said, it might be wards, it could be particular market towns, it could be neighborhoods or communities, it could be particular population groups, and that might relate to their health, could be ethnicity, could be age, could be all sorts of things. So the point of that is understanding the needs of those populations and the demands of those demands and services that we might supply to support those communities. And in recognizing those, I mentioned the different contributors to our health. Well, lots of people have studied, have attempted to study how much the wider determinants of health and other determinants of health impact on our health outcomes. And this is one summary from University College London. And what you can see, it's quite interesting that they estimate actually our health. Social economic factors are like education, employment, income, social care, community support are really important contributors to our health. And they say it counts for 40% of our health outcomes. And that might come as a surprise to you, but if you were to go to other countries, less developed countries, you would probably recognize that much more strongly, and particularly the sort of environmental aspects as well, poor housing quality. But what you can see down here is healthcare only contributes to about 20%. And this is why population health is really important. It's recognizing all these other factors are really important to our health. We need to understand them to get a more holistic picture of what's going on in different communities, populations, and even patients. So then the next slide. So population health has become a key. It's first started getting mentioned in the NHS plan about 7 years ago. I think the NHS plan came out. but it's now become one of the core strategic aims of NHS England, and central to the delivery of what's called the new integrated care systems, that all of England's been divided into 42 areas, and they're calling them integrated care systems. And the idea there is to join up primary care with secondary care, with mental health services and community health services and social care services, and make them work together much more integrated and less fragmented way. So you may be familiar with that. So population health management. So moving on. So what does that mean? It's about using data to help understand needs in the community and to facilitate the planning and delivery of proactive healthcare, so preventative healthcare, to have impact on population health. So a lot of it's about prevention. It's about reducing inequalities in health and using linked data sets to do that. So to do that, we have to segment the population. We have to cut it into, look at different groups in the population and stratify according to the risk, how healthy, or the risk of them becoming unhealthy in the next week, month, years. And you can do that by modeling, called computer modeling. This is just showing what's called the triple aim. The triple aim was developed, which was about improving the experience of healthcare and the well-being of the population, and also reducing costs, which was developed in America actually. But in terms of population health, people have developed that idea into what's called the kind of quintuple aim. So also including health inequalities, improving health, as well as increasing the well-being of the population. So population health is about using data to help us understand the needs of the population at a very segmented level, so we can then design services to help prevent ill health, or actually address ill health as it manifests itself more generally through primary care, secondary care, mental health services, etc. So what's that mean in practice? So, well, as I mentioned, it's analysing what we call linked data sets of lots and not just health, joining up primary and secondary care data sets. Say a little bit more about that. Cutting populations into bits in which makes sense around age, sex, ethnicity, might be communities, to better understand their needs and promote their health and healthcare. It's about risk stratification, so better understanding which populations are at risk of poor health, so using data to help us understand that more, so we can then again target those populations. It's about understanding how patients access or use multiple services over time, so it's about care coordination. And you can use the data as well to help us model or predict for planning or making decisions around where we spend our resources. So that might be understanding how patients flow through the system, come through the system. So it can help make more integrated care pathways and plan for those. It can also be used to think about, well, if I do this intervention, we think we see this need and we were to implement this, what's going to be the impact of that, and who's going to benefit and who might not? So that's what we call impactability modeling. And as I mentioned, it can help with us think about how do we cut up the pie of the resources to make the most of the money we have to get the most benefit, but also ensure equity within the system. And kind of finally, another key area is about how do we use this data to help us evaluate what we're doing, new interventions, existing interventions, better and more rigorously. And that can be process data or health outcomes as well. So there's a real opportunity to explore new models and methods are all more robust than perhaps some of those being done already. But also, I think it's important to recognise that it's about making informed judgments. It's not just about analytics. So data is just a tool to help us make better decisions. And the data can help us in a number of ways by enabling us to make more better insights, understanding people more holistic way, or communities more holistic way, and having better insights as to what their needs might be and what they might benefit from. It's also, to do that, we need to create equal partnerships, because different players and stakeholders across the system will have a different view about health and what might benefit them, and that includes the public too, and patients. So then it's about how we prioritize and make the best use of our understanding and the resources that we hold to get the greatest impact, and to make real tangible difference to people's lives and health. But this is so how does this, just I put a little caveat at the end, but I said it's not an integrated electronic patient record, certainly not at this stage. So the way the government have framed it is electronic patient records is about, on one side, which is about joining up electronic records for direct patient care at that point in time that you access care. So there's a push to join up data sets there, but population health management is much more about using the data that's already being collected in an anonymized way and linked for service planning and to the functions I've just outlined on this side. And currently there is a recognized divide and between the two. And you can technically opt out of population health management, and you have the right to do that your data is not used for such purposes. Next slide. So population health management, as I mentioned, it comes from population health, but actually more recently, people have been talking about population health management, and the NHS England have been supporting the delivery of the idea of population health management. How do we do this in practice? And about 4 or 5 years ago, the NHS England paid a company called Optum from America to come and support different, more mature systems. There were 4 systems across England, what we call integrated care systems, which used to be the old larger CCG footprints. Those are more digitally mature. To work with them to use join-up data and start to put this into practice, to create a stronger culture where we use data to make better informed decisions. So create a much stronger culture in doing that, with the aim of reducing inequalities and improving health of populations. That program rolled out Wave 2. Devon, where Felix and I come from, was part of Wave 2, and that happened during COVID. And we actually watched and monitored some of those as part of the work we were doing around social prescribing, which I'll talk about a little bit in a minute. And then currently they've moved to Wave 3 and 4. So virtually all areas across England have had some input about how to support them deliver population health management. And it's been very much a journey. So you can think about it, on one level, it's about improving the infrastructure. So by the infrastructure, I mean the data infrastructure. We know there's lots of different data sets out there. They're all slightly different. They're all have different systems. They don't talk to each other, etc. So it's about unifying and bringing that together. Then it's about intelligence. So how do we use that? How do we interpret the data much more intelligently? Who needs to be in the conversation? How do we interpret this in a way we get a all-rounded, nuanced view of health needs? And from that, we can start to deliver interventions that use those insights to start to formulate and develop and test and learn those interventions so we can refine them, ultimately to deliver impact for patients and populations. And these are sort of the challenges I've put along this I've seen it as a kind of pathway, a roadway, if you like, to achieving that. So linking of data sets, working with lots of different players and stakeholders, where a more mature system will have a full linked data sets, which involves the wider determinants of health rather than just primary, secondary, social care and mental health. So really pulling in other data sets from across statutory organisations and across the systems, until, really well developed systems where the actual systems really invested in the whole idea of how we use data, training up people and staff to use that data, have the skills and abilities to actually use it more appropriately. I just thought we'd quickly mention what we've been studying in Devon, and we've been looking at the Devon 1 data set. And that data set, as I mentioned, as we were part of Wave 2 down in Devon, we followed that journey. And the first part of that journey was linking data sets and bringing in different data sets like general practice data set, which most of the general practitioners have signed up to now in Devon, but not all, because some are nervous about the potential risks to them of the data perhaps being used in ways and processed in ways that they didn't anticipate, and the GDPR around that. We've pulled in the acute data from the hospitals, the 4 hospitals in Devon. We now have community services data pulled into a big data warehouse, and they're all linked by the individual. So they're all linked back to one individual. So mental health services, the Devon Partnership Trust, we pulled in the adult social care, but we haven't really, we want to pull in the wider determinants of health. And by that means it might be individual data around employment, it might be around housing, it could be other areas. benefits, we could pull into the same data set based around the individual and the person. We haven't started really to do that in Devon, but some areas have. And others are pulling in things like ambulance, data from care homes, housing, etc., 111, and ambulance service. So this is the ambition to do. And as I mentioned already, social, we've used this data is being used already in Devon, and one area is social prescribing. We actually used it ourselves in a social prescribing project during COVID, and this led to tangible benefits to the system. The data we used and we fed back helped change the funding patterns at a national level, so social prescribers to give more managerial support. So they got £3,000 across the whole system. We had a dialogue with NHS England around that, and they understood what we were saying to them around that and acted accordingly. And also we fed back our learning to local systems as well about what we found when we used this data. And there's been some more sophisticated analysis on social prescribing since. So it's quite interesting. So why part of the reason we reached out to My Data and Chris and the team is very much around the research that we want to research what's happening. We've been researching it in Devon and trying to understand how it's working, what's working, what can make it work better, and feeding that back to system in a sort of iterative learning way, so we can try and strengthen what they do as they roll it out, but also learn from the whole process. And we want to do that across the whole of England. So what we realize is there isn't much evidence about how to do this well, and not great understanding. It's very kind of ad hoc and patchy. So we want to look more closely at implementing population health across integrated care systems across England, how they're using key and supporting delivery of a raft of policies, things around tackling inequalities and personalised care, anticipatory care, etc. Recognising that primary care networks and GP practices are a key part and need to have a key active part in population health management. There's a real opportunity, recognizing there's a real opportunity here with, as we join up these data sets, become quite big data sets, and particularly we can pull them historically. There's a real potential and richness of that data to learn and get very insightful understandings of situations. But as I said, there's a real variation in terms of digital maturity across different integrated care systems, lots of people doing it lots in different ways, understanding how this is being used at a system level, at what we call a place level, like town level, or wider footprint than that, and actually like primary care level, neighborhood level. We know that some have a very top-down approach, and others trying to make changes and use this data from very bottom up. So there's no blueprint of how to do this. There's some evidence from the Netherlands and the USA, but they have very different health systems in themselves, and they're not like the beverage-based system we have in the UK. And there are we know there's lots of instances of good practice and opportunities to learn from each other, and that's what we want to do with our research, bring that all together and share that more widely. So we really want to get, in doing that, we want to engage the public in helping us think about what are good questions to ask in our research. What should we be focusing on looking at? Felix, do you want to I'll hand over to Felix, who's going to talk a little bit more about our research proposal and
yeah, thank you. And we're mindful we're racing through quite a lot of stuff here, and we are academics, so we're always learning to improve our delivery. So if you've got any questions, clarifications, please do use the chat, which I've got an eye on as well. So the timing is really impeccable here, because we are doing a piece of work already. We know some stuff is emerging. We've linked to national people in this space. There isn't much, so it's good opportunity to do research as justified by Julian, but also it's a good timing because we're just at the beginning of writing it. So to engage with members of the public is perfect timing, because it's very open at this stage in terms of where we focus down on. We have the ambition to look at nationally, at least in England, what everyone is doing, to just deliver a map, and then we can go as deep and focus down into areas of particular interest to your members if we can. And there's a clear remit by the funder where we go to, and we'll submit kind of a stage 1 proposal probably in February. We haven't got a deadline yet, so there's plenty of time to do a bit more learning with you guys, and maybe have another session if people want to volunteer to work with us and be written into the bid and reimbursed to go on a journey with us. So that's basically summarizing what this slide says, understanding how it's implemented and rolled out, you know, kind of a map, basically, the key features of how this has been rolled out since wave 1, looking for barriers and facilitators, which is a simplified way of looking at all the complex things that will be happening as they do in Devon. And then, you know, always with an eye to how is this actually going to benefit us as residents ultimately. Yeah, there's no blueprint. What is actually happening, you know, at the level of innovations at a primary care level? What do people actually do with this data to change services? And yeah, and be helpful, but also critical friend in the process. So I think we're always mindful that as academics, we have a particular responsibility and an opportunity to not to help by learning, but also to be an independent view onto the dynamics that might occur at local levels. We've got a set of questions, but I think I would almost open the floor. Well, these are the steps, kind of the plan we've roughly outlined. So there is an NHS Futures collaboration platform. People might know this. I think you can sign up to it and join it as well. I'm not sure if you need an NHS email address for it actually, but there it's kind of a virtual community of practice. So all the analysts, managers on all sorts of topics concerning NHS England and other integrated care system stakeholders. So it's hosted by NHS England, but there is a couple of forums on population health management where we've been active members, and which in itself is a rich source of data. And we've analyzed some of the chats as well there. But the idea is to put up a survey with key informants there to kind of have that open, so what's happening in your integrated care system, and have a kind of a structured online survey. We would try and get as many documents from systems themselves, in terms of audits, performance documents, strategy documents. So each integrated care system, I think by the end of this financial year, each integrated care system has to have a roadmap for population health management rollout. So those will be submitted back to NHS England, and we want to see those and analyze them qualitatively. And then we don't know how many we will be able to resource to actually go down deeper and to really drill down and find out at a more granular level what is happening. So there'll be in-depth case studies, any number of them. We might well end up trying to go as deep as we can with all 42, but we don't know yet. And it's more a question of resources and access than of the rationale for why we would pick out certain ones, because you then methodologically it's challenging to justify, are you going for more mature systems, compare them to those that haven't done much in this space. So we'll see about that. But most importantly, also we'll look for innovation. So where services have been changed, pathways newly designed, new innovations that might have emerged and what impact they might have had. And then there is a clear work stream around involving members of the public actively in any stage of the research process. And that can be, preferably for me, it's working really as part of a team, but it can be in a more advisory oversight capacity. Okay, so I'll just have a look at I think that's where we are at the moment. We've kind of outlined a few research questions. I don't know how deep we should go, whether we should just field some comments, or whether these might be helpful to kick off a discussion in the next half hour. It's about defining. Yeah, go on, Chris. Yeah, go on.
I'm just going to say it's a good opportunity just to open it up to people and say, do they have any questions about what they've heard so far? So that's a really good run through of what is population health, what data is needed to monitor it. What's the art of the possible, really? I wonder whether anybody got any questions generally about whether that helped them understand what population health and population health management actually is, or whether the things are unclear. Use your hands or stick things in the chat or whatever you prefer. I'll pause for a minute because I know Jackie's got one specifically on a question about the data sets. No, I hope that
I
made
got
sense.
a question. I can't get into it. Can I have a question now?
Yep, go for it, Nanette.
Sorry, something is not wrong with my iPad. I can't get where I want to get. How do you get people involved? How do you get the public involved? Are you sending out questionnaire or certain, organization, or how do you make patients aware of this research project?
Yeah, it's a very good point. Thank you, Nanette, for asking it. So there's things we can do as a research project and that we can resource in terms of having starting to talk about that in the study sites where we are, advertising it, speaking about it, recruiting people to become part of the research project. What we're more interested in is kind of how have people out there in the real world done it, and they've done it in various ways and on a very hyper localized level with the type. I mean, what's happening in Devon at the moment is that there is a number of action learning sets which have got an educational remit to bring around different stakeholders from different part of the health and social care system. So it'll have primary care directors, primary care managers, it'll have the social prescribers there. There'll be people from mental health, there'll be people from the voluntary and community sector, and they come around to look at this data and they go through a kind of a 5-step action learning set process. And they might decide to bring in people through the voluntary and community sector. There is the patient participation groups in primary care that we haven't actually in Devon seen that they've been part of it, but there is certain statutory remits for something like a local authority who's often got a remit to engage with the public. So we're interested in how are those being used, those means of involving members of the public and being held to account are being used in the process of rollout. So we're more like interested in the research. The research is interested to see how members of the public have been sat around the table in those processes over the last few years or going forward. But in our remit as a research project that is separately funded, we will have at least 2 people that become part of the bid writing process. So they'll be written into the bid. They will be helping us form these research questions. So there's 2 different ways, I guess. One is we want to find out how they've done it out there. And then we have a personal remit and control over how we involve members of the public in the research process itself. And hence we've approached Use My Data today. Does that answer your question, Annette? And I do struggle with, I'm German, so I do struggle with English as well. So it might have been, I might have gotten lost in translation.
Yeah, I think one more question is how do you how do you choose people? I mean, I know we go after ethnic groups and this and that, but a lot of people, we still put the ethnic group were actually born here. Children are growing up. Is it just in general question, or you look into where they come from, their illnesses or whatever? Because as I said, things have moved on. People may not be, maybe originally from somewhere else, but they grew up here and they, I went to school here and work here, and they're still treated as belonging to a certain ethnicity group. If you understand what I'm trying to say.
Yeah. So I think it's a really good point around protected characteristics, and I think that's definitely something that will come out of the data, because it's such, as you've seen, it's such a qualifier of access and unequal access to health and social care services and support. So we'll be interested, and we can make an emphasis around how protected characteristics like ethnicity have been an element of how each integrated care system has emphasized. And yeah, so it'll be a good measure to how inclusive this process has been in each integrated care system. So I think it's a welcome steer to see to have a specific focus on protected characteristics there.
Yeah, I think there are two elements to that. One is, as you said, Felix, how the data is used to really look at inequalities and that kind of variety of ways. It could be protected characteristics, could be related to access, could be related to groups that have faced discrimination and racism, as well as groups that have social economic challenges as well. The other element of it is actually in the delivery of the research, and we are, we're very keen to engage a mixture, a range, could be patients or members of the public, really, in helping us deliver the research, but also disseminate it as well. So how best to disseminate the research, and I think that's an important area too of what we find, because for me there are two areas. One is the kind of strategic level about how linked data sets are being used and how a member of the public being engaged at that level. And that's really about, for me, it's about ensuring trust and transparency. And that's clearly one of the issues that we found in Devon. That's why there's a reticence to join up some data from some GP practices, not all. 99, I think about 97% of our GP practices are now signed up to linking their data, but not all. And then the other level is, so that's about how we manage and who has access to that data and how it's used, and is it used in a way that delivers benefit to, say, patients, members of the public or populations. And then the other level is actually when we get down to the actual practicalities of those projects that go ahead using this kind of data, how have members of the public or other stakeholders that might represent them been involved, and how important has that been in terms of I would say gaining insights and developing innovations. So, because, it's interesting when we've talked to other areas like Dorset, they found bringing on members of the public, for example, into those conversations based around the action learning sets that Felix mentioned, has kind of helped move them away from the medical model of thinking, because you tend to have more clinicians and medical staff and medical administrators in that space, and actually moving them to more sort of social, holistic models of thinking about health and what's going to benefit the patients. So that's what we're anticipating, that engagement will really make a difference. So that's what we want to investigate and see if that's happening and what difference it's making, I would say.
Julian, I'm going to bring Jackie in because she's waited very patiently. I have to type in a question in there. She put her hand up specifically about nutrition. So you talked about the different types of data sets in our world that are out there. She's pointing out nutrition is a major determinant of health. And as well as other factors, lifestyle factors like exercise. How would you organize nutrition data?
So I'd say, sorry, I'll just jump in here. I would say what the linked data sets allows you to do is to connect data sets. You get a much rounded picture of what happens. So you could take rickets. I think you mentioned rickets there. So you could look at who's getting rickets and what communities they come from, and how often they've been involved in the health service. How quickly was it picked up by the health service? Are they coming from certain communities? We know that some communities exposure to sunlight is more restricted in some communities. And that potentially could have an impact, for example, on lack of vitamin D production and implications for fetuses and things like that. So the data, by joining up secondary data and primary care data, the data in your general practitioner, linking that with other data sets I've mentioned, but also bringing in the wider determinants of health there, gives us a much broader. So there's a real opportunity to do research in its own right, but also to think about the services that you might help deliver to deal with that issue when you find it. So one would be to scale up, and it's to identify it and then understand it about which communities, where it's happening, how frequently, in a much better and rounded perspective. I hope that's answered your question.
Yeah, I was watching Jackie. Actually, do you just want to drop the slides, Felix, so we can probably see more people?
Sorry. I'm so sorry.
Temporarily. And I can see Jackie's lips moving, but I'm not hearing anything coming from her microphone.
And Abby's got her hand up as well, I noticed.
Yeah. Go, Abby.
I'm happy once Jackie gets back so we can hear her. I'll just fill in with this question in the meantime. So you guys, you're probably going to get this from various professionals and healthcare providers and things. So my background is I worked for nearly 15 years in local government in social housing, and I used to work next to the private sector team. So for me, when it comes to the wider determinants of health, actually the impact of somebody's health is, from what I've seen, is much higher than 10%. It's basic Maslow stuff of if you do not get your base right, education doesn't follow. So actually the housing is more important than the education. And there's a couple of things. There's more like just a contribution, really. So really that is important. How are you going to involve, because it's all very well having, you know, the high level people, but the actual foot soldiers on the ground who need the evidence, you know, to actually be able to, their gut instinct that you're talking about as well sometimes, you know, to help to make change policies. And then also, because part of that is it's almost like a generational thing now of chaotic lifestyles. You know, they come down the generations the same as deprivation. And sometimes you will have people out there who don't actually realise, because they're so used to living in chaotic environments, that their housing really and the lack of that stability really is impacting. So they might say to you, I need, you know, I want my doctor to see me more, or I need this, or I need that, when actually what they really need is really good housing and a safe base. But they just don't realise that because they've never had it. You know, and this is across the spectrum. So how, yeah, sorry, there you go. How are you going to factor that in?
So
go on, Felix.
Yeah, I mean, I've done research around children's services, early help, and I'm just writing a paper on housing, well, on the coastal challenges in particular in housing, and it's just interesting. The dynamics of the local authorities are just so siloed, aren't they? So even, you know, the link between early help and housing is so obvious, isn't it? And the social gradient is there everywhere. And, you know, we've worked with Paul Bywaters, who's a very prominent social care professor, semi-retired, who's given his time for free, and the insights are just not there. The data is not linked on a national level. It's you know, housing research, you know, from an academic perspective, it's in its infancy. But more heartbreakingly, the housing department doesn't talk to children's services, nor do they talk to public health. Housing stock is so variedly organized. But like you say, like yourself, the housing officers are they have such an insight and sense for the understanding of wider social determinants. In Devon, we haven't got the housing data in, but even at the district level, the housing officers have such brilliant data, which almost isn't poolable. So the question from a research perspective, the question is, how can you have data that is really powerful at a more, not an individual, but a more population or neighborhood level granularity? How those voices by those brilliant housing officers coming in without the data? So we're interested in how does the intelligence on a local level match with what a data set, and it might be the limitation of a pooled data set because it's so geared towards biomedical issues and the activity in NHS and social care sector. So it's a real fascinating project, project to kind of find out how that works. We don't know how it works, but we know that we do everything in terms of our remit to engage voices. You know, I don't think anyone is hard to reach, but to disentangle those voices. But what we've done is spending 2 years in the neighborhoods in one of our cities, really going down and finding those voices. It takes a lot of effort really to surface those intricacies that you've described, but it's not impossible. What we're doing with this research project is looking nationally and seeing what we can find that people do that is inclusive of housing data, housing lived experience, as well as the expertise from all the professionals involved. Not sure that answers it, but it's very pertinent, a big, massive social determinant.
Yeah. Could I just add very briefly? I think it's a really key question that we all know housing is so important. We've got a national housing crisis, so a really important point and illustrative of the impact on health inequalities that housing plays. The question is for the data set is actually what the linked data sets potentially give you is a longitudinal look at that. So looking over many, many years of time, so you can see the cumulative effect of that as well as the real challenges that, you know, some Felix outlined there. And I know I'm doing a project in social care, which is looking directly at the impact of housing on the delivery of social care. And we are really struggling to get the linked data, even within the local authority. So there's a lot of work to do there. So it'd be really interesting to get the learning around the country about how they've done that, how much data, how they've linked it, what impact it's had. So that's what we'll be looking out for, and then sharing that to encourage others to do the same, ideally.
If you're looking around the country at the different integrated care systems to find out what they have done in this area, are you also going to look and ask them what their blockers have been to do things like linking housing data with other data? Because I think one of the key things that you could get out of your look across England is, what are those blockers? And in particular, from our perspective, how can some of those things be explained to, in this case, the public, and get the public voice to unblock them? And I can see Brenda's nodding at me as she thinks I'm a clever person, or she's probably nicked her question. Brenda, did you want to raise the same thing? I'll let you speak now, and I'll shut up.
Yeah, very, very similarly, I was going to ask, do you think that if you start bringing in other data sets, particularly employment and particularly in benefits and even housing, you're going to increase the number of people who want to opt out? Basically, that whereas people might trust health data, they may be less trusting of all this other data, you know, things like care, home care. I always think to somebody, would you like your data known and shared amongst these data sets? How much would you trust it being anonymized? And I think the more unfortunately, I can see why the data is wanted, but unfortunately, and I'd like to know the panel's position on this, what their view is of it, because to me, I'm wary that if you increase the number of data sets, you unfortunately increase the suspicion of the public, and especially those who've got something to hide, maybe. But they're the numbers we need. We need people's data, even if they've got something to hide.
Well, it's a really important point, I think, and the whole behind that, I think, is the element of trust between the public and kind of the statutory organisations who are there really to serve the members of the public, but we know actually don't always do a good job of that. And actually, with austerity and some of the financial measures, a lot of public services have come very siloed in the way they operate. Thresholds have come very, very tight. So a lot of people are bouncing around the system, and I think they feel very frustrated and probably neglected. So I totally understand where you're coming from. So I think it is, for me, transparency is a really important part, and demonstrating the value of this data in a positive way. And so there's no easy answer to that question, because I totally get what you're saying. I think there's a big technical challenge here as well of doing this. So there's the actual governance issues about how you do it and how you process people's data, and if you have their permission to do that. And then there's a technical challenge of making sure it's the right systems, it's compatible, what they call interoperable systems, so you can pull the data and you can put it in a way that's useful. So there's a lot in there to actually even achieve that. But I think those are the kind of things that we'd be interested to hear from, and also from the panel, and how areas have gone about addressing some of that stuff.
Thanks, Julian. Abby, let's come back to you.
Yeah, I'm going to jump up in a minute. Sorry, my battery saver's just come on. So interesting. Now we come on to this one. I get what Brenda's saying, and I'm having a discussion with some other researchers about the use of routinely collected data in RCTs, because I'm somebody who actually wants to be identified back. But I think the issue, so there's two things, and one of the things that I read on your slide somewhere, or the briefing note, is I feel very uncomfortable about pseudonymized data, particularly since the Gold Acre review and all that, and I'm much more comfortable with anonymized completely. And, you know, if you're going to track me just by one number, and there's only one person who's got that can do that. So, and how I'm sort of like presenting it when it comes to routine data is, the best way is to show people how they can make a difference by letting people have access to their data. You know, give them case studies. And one of the ones that I'll give very quickly is, I've been giving blood for years, but very recently, the last few years, you start to get a text message now, and they will say, your blood donation has gone either to this hospital or it's gone to that university or whatever. And it's like, oh, wow. But God, and that makes you then think, whoa, they're using my blood to do something really, really good. So it's how are you going to present it? Because I think when people realize the benefits of sharing their data, they're then a little more willing to do that. So two things, sorry.
Yeah,
it's easy ones.
Go on, Chris.
No, I was going to say that nice, easy questions, and
I think
you answer those things.
I think the way we pitch this research project is that there is no one looking at this at the moment, but we want to map out all these knotty issues. So I would say we want to illuminate and educate around it as much as we can, at a very comprehensive level. So these are all, and then you could see that you could have sub-projects emerging. I mean, researchers, I try not to, but researchers always like to conclude that there's more research needed. But I think what we're going to do with this is just to set out the map and understand and name those things really good. And then your process about feedback loops. And I mean, we do that. Researchers, we're trying not to be extractive researchers, because that's what happens. We're just like everyone else, take the data, write a report, and never to be seen again. So feedback loops ethically are really important. But what I hear you say, Abby, is to really make sure we if we do, if the public involvement element of the research project is all about communication, then we can substantially resource that to have a real comms and education campaign nationally coming out of it. And I think that's the steer I take most from what you say. In terms of locally, yes, I mean, it's about culture. It's the trust is the interesting thing, and then it's also about paradigm and culture shift. When you talked about housing, and the comment that Julian made around failure demand, this is the John Seddon stuff. If people bounce around the system, especially with complex need, it becomes more costly ultimately. So what, the chances and the things that we have seen, for example, the temporary housing budget, it's the B&B budget, which always explode the housing budget. And, if you just waiver the rents and keep people in stable housing, it's those nuances that you can then show. And then the practice around de-anonymizing, pseudonymizing, I think that's, we're just keen to see how people have managed that.
Yeah, and it's a good question, isn't it? Because actually that's been, in the action learning sets, that's been something that we've seen. So you're quite right, with the pseudonymized data set, you can actually re-identify people. So in the action learning sets in Devon, when they decided on use the data to decide on the area they're going to focus on, and then they've identified the primary care networks who are going to work on that issue, and they've identified a target group, then what they've done is they said they've given the pseudonymized numbers back to those practices, and then they've given them a key to re-identify them, so they actually could do a personalized intervention with them. So it's interesting. So while you're one level, I understand that when it's I think the law is slightly different around anonymized versus pseudonymized, is my understanding. You might have a better understanding than me, but that's my. But there are some advantages of pseudonymized as well. But it's one of those areas that's got to be handled really, really carefully, I would say. So it's important. It's an important dimension. I hadn't thought about it until you just mentioned it. So thank you for raising that.
And then there's a use request panel. There is a committee and a panel. And it'd be interesting to see how is that managed? How are the members of the public involved in approving certain processes of innovation and data processing there? And I mean, what I'm interested in is what happens at a local level in terms of the capacity for people to do more holistic care, and move away from a biomedical firefighting and risk management process to something that looks at going alongside people in a holistic way. And I think that's more, and I think it'll still be a balance between clinical judgment and professionals involved in a multidisciplinary, multi-agency support system, rather than what the data says, because the data, it'll just be too complex and overwhelming. Our brains are not well suited. Anyway, those are just lines of inquiry that I find fascinating. Sorry, go on, more questions.
Well, we're going to test your microphone again, Jackie. No, not working. I'm going to read what you said. It's the first time I've had Jackie on a problem with technical. First of all, she's put some points in the chats. Agreeing with Brenda, data needs to be ring fenced so some state agents don't get access. Raising the point that you need more than a couple of patients, PPIE people on your team. And we can certainly help you do that. I think you've heard some real interest here. And we've got another few hundred people who couldn't attend today. And Jackie said, I'm sure Chris will be mentioning trusted research environments at some point. So I can mention trusted research environments. But I'm not sure. I don't know what the context would be really. So I suppose if you're looking around the country about trying to find out who has done what, the key things for me are that I've had feedback from people who couldn't attend the session. Is the sort of governance side, which you described. Where is this data you'd like to use? How can it be managed either locally or nationally? And where do those things fit? Have the ICSs, the integrated care systems, gone for a purely local system because it's safer? And if so, why? Or have they gone for a national or a hybrid? So how is the data managed? I'm not going to get into the point about pseudonymized, anonymized, because we did do a small session on that, part of a session a couple of years ago, and I'm feeling we might need to run proper education session on what we mean by anonymized and pseudonymized and anonymous, because that's influencing more and more. I'm conscious that the Information Commissioner's Office are still due to put their report out about their recommendations on this. So I think there's a lot up in the air on that. The trusted research environments is essentially a way, technical infrastructure, where you can hold data securely, let's say, but instead of giving linked data sets out to people, such as researchers and others, those people are brought into the secure data environment, the trusted research environment. They get essentially given a login, so the data never leaves. It's a safer way of giving access to linked data for people, but you still need to be able to get the linked data in the first place, and you also need to get the public understanding of what it is you're trying to do and to link and why and what the safeguards are. And as you're looking around the country, I would also recommend you think about finding where patients or the public have had a decision-making voice rather than just an advisory voice. You talked about data release committees where some people sit and decide whether somebody should be given access to data to do research. It'd be really interesting to know when you're walking around the country with your ICS map, how many times have patients or the public been given a decision-making voice in that rather than just an advisory voice, which could be overridden. It's a whole bunch of things coming around that. And I'm conscious of time. Is there anybody else wants to flag that they've not heard? In which case, I'll probably, in the last 2 minutes, try to summarize that. So I think there's two bits we've heard. One is around what population health management is, what it could do, and the art of the possible. And it seems to me that there's a vast amount of knowledge we could glean for real public good by linking, as Abby said, housing data and education data and health data, a whole bunch of other things. But that's a technical perspective. There's the governance and the technology around doing that. We've also not talked about whether the data quality is any good, whether you can infer the right results from it. But then I think what I also heard is, let's find out when we look around the country, how many of those localized groups have really talked to people who know what's happening on the coalface? Or is it just the integrated care system bosses sat in a room making decisions without actually talking to people who are on the ground, who know what the most important things is? So I think as part of your research, mapping out what people have done around the country, that seems to be really important. And a whole bunch of other things that have come up on the webinar on this session as well, which I hope we found useful. Julian, Felix, was that, we've run out of our hour now, was that helpful to you in terms of getting feedback on what you're wanting to do around the country with your research, first of all?
Yeah, very, very helpful, and a nice summarising of some of the issues and areas to focus on. So I think we're definitely going to take that away. This piece of work is not just about the public involvement, but it's potentially really huge. So the public and engagement, involvement, and those issues just outlined will be part of that, but it won't be the main focus of that. Yep. And then, as Felix has outlined, we're really keen to engage members of the public, members of your organisation and other similar organisations who have an interest in this area, to support and advise us around shaping the questions, interpreting really what we're finding, guiding the research. There are different ways to engage in the research project dissemination as well, ideas around that, and how we can reach back to groups that you connect with, as well as bodies like NHS England, etc., who we also hope to engage and have provisionally given us their support for this project.
So I think we're probably going to need to draw it to a close there. I think we'll follow up with the two of you after this. We'll send a link to the recording so you can take any more notes you need to. I think from us, it's been really interesting to know where we could help advise, steer your individual projects about how you want to do your thinking. And indeed, from the wider perspective, what questions we think you should be asking of the IC, of the integrated care systems as you go around the country. So I think this is a start. I'm getting the feeling that you sparked an interest amongst people to play a more interested role in what it is you're doing. So maybe if we can follow some things up after this session about what might be helpful for you to do next with us and with people who want to be more involved. I'll also drop a note to everybody who's attended here just to say, was that helpful, and whether things were not covered, on other things you want to ask as well, and maybe even to follow up, if that's okay. Excellent.
Brilliant.
So I'm sorry that was another really rapid hour, goes too quickly. I'd like to thank the two of you for giving your time and preparation to do this. It's really helpful to us to hear what you see as population health and health management is. I'd like to thank all the people who've given their time on a really grubby Monday morning in the north to bring your questions. I hope we've answered some of them, but if there's anything else you've not asked or answered, you can email me or Elizabeth or Alison, and we'll pick those things up. And I'll also drop everybody a note after this, but it might not be until later or even next week. So I think we'll leave it there. Thank you to everybody for your attendance. Have a good rest of the week. And we've got another session on Friday about social care data specifically. So if you're not registered for that, feel free to register for that.